chronic kidney disease, CKD, is a type of kidney disease in which there is gradual loss of kidney function over a period of months or years. There is progressive reduction in nephron mass, and this means the damage is irreversible. The stage of chronic kidney disease, CKD, should be determined for all individuals based on the level of kidney function, independent of etiology, in accordance with the Kidney Disease, Improving Global Outcomes (KDIGO) classification system. Quantitation of urine protein excretion, such as the measurement of a spot urine albumin to creatinine ratio, is critical for determining the severity of CKD and monitoring the rate of disease progression. The glomerular filtration rate, GFR, is the single best indicator of kidney function. Measurement of the GFR is most accurate when performed following the exogenous administration of inulin, iothalamate, or radioisotopes such as technetium-99 diethylenetriamine pentaacetic acid, 99 mTC-DTPA. Equations to estimate creatinine clearance or GFR are commonly used in ambulatory and inpatient settings, and incorporate patient laboratory and demographic variables such as serum creatinine concentration, SCR, cystatin C, age, sex, weight, and ethnicity. Assessments of kidney structure and function, such as radiography, computed tomography, magnetic resonance imaging, sonography, and biopsy, are predominantly used for determining the diagnosis of a given condition. This table shows the staging of chronic renal failure based on glomerular filtration rate. Stage 5 of chronic kidney disease with GFR of less than 15 warrants dialysis. The decline in renal function correlates with interstitial fibrosis and tubular atrophy. The most common cause of CKD is diabetes mellitus, followed by high blood pressure and glomerulonephritis. Other causes of CKD are chronic pyelonephritis and polycystic kidney disease. Still other causes of CKD are idiopathic and often associated with small kidneys on renal ultrasound. Pathophysiology of chronic kidney disease begins with initiation of renal damage. This leads to reduction in renal mass. There is hypertrophy of the surviving healthy nephrons. The remaining nephrons eventually undergo sclerosis. There are two types of renal failure: acute and chronic. In acute renal failure, the course takes days to weeks, while chronic kidney disease has a course of months to year. Acute kidney injury has a potentially reversible prognosis, while chronic kidney disease is irreversible. On ultrasonography, the kidney size is normal for acute kidney injury, while in chronic kidney disease, the kidneys have shrunk. While dialysis is possible treatment for acute kidney injury, in chronic kidney disease dialysis and kidney transplant are the definitive treatment. There are several conditions with normal kidney size, such as diabetes mellitus, lupus, progressive glomerulonephritis, amyloidosis, HIV-related renal disease. Chronic kidney disease has several complications. One is anemia. The mechanism of anemia in patients with chronic kidney disease is due to erythropoietin deficiency, especially when GFR is less than 40 ml per minute. There is diminished production of RBC. Aside from diminished production, there is also hemolysis, shortened RBC survival, and bone marrow suppression from toxins and infection. Deficiencies in iron, folic acid is from anorexia and malabsorption. Another complications in chronic kidney disease is renal bone disease. CKD metabolic bone disease is an alteration of bone morphology in patients with chronic kidney disease. It is a systemic disorder of mineral and bone metabolism due to CKD, manifested by abnormalities of calcium, phosphorus, PDH, or vitamin D metabolism, abnormalities in bone turnover, mineralization, volume, linear growth, or strength, and vascular or other soft tissue calcification. There are types of CKD metabolic bone disease. In Osteitis fibrosa, there is high bone turnover disease caused by secondary hyperparathyroidism. Its manifestation are bone pain, fractures, proximal muscle, metastatic calcification to myocardium and periarticular tissues. In the parathyroid regulation of calcium, the decrease of calcium in extracellular fluid and hyperphosphatemia leads to increase in PTH. This increase leads to increased vitamin D3 activation. It can also lead to increased renal calcium reabsorption, and increased calcium release from bone. The increase in vitamin D3 activation leads to increased intestinal calcium absorption. The other type of metabolic bone disease is Osteoma Lysa, which is caused by aluminum toxicity and vitamin D deficiency. It presents with proximal muscle weakness and wasting. In the pathophysiology of renal disease progression, whether it is caused by glomerulonephritis, hypertension, diabetic nephropathy, it will lead to increased intraglomerular pressure. This will in one way lead to glomerular sclerosis. In another pathway, increased intraglomerular pressure will lead to protein filtration, protein reabsorption, then to release of numerous cytokines, and eventually leading to interstitial fibrosis. In this flowchart, this explains renal blood flow and its effects on glomerular filtration rate. A high-protein diet leads to increased amino acids in blood and increased filtered amino acids. This then leads to increased amino acids and sodium reabsorption in the proximal tubule. With that, there is a decrease of sodium in the macula densa, leading to increase in angiotensin II, increased glomerular filtration rate, and eventually leads to increased filtration of urea from protein metabolism. This other flowchart shows the effects of hyperglycemia to renal blood flow and glomerular filtration rate. When there is hyperglycemia, there is increased glucose filtration. Glucose reabsorbed along with sodium in proximal tubule leads to decreased sodium in the macula densa. These in turn leads to increased angiotensin II and eventually increased glomerular filtration rate. The ways to delay progression of renal disease, such as glucose control, blood pressure control, control cholesterol, stop smoking, and restricting protein intake. There are several dietary modification in chronic kidney disease. Protein is restricted to 0.6 to 0.08 mg per kilogram per day. Calories are computed at 30-50 kilocalories per kilogram per day. Potassium is restricted to 40 milliequivalents per day. Phosphorus is restricted to 800 milligrams per day. Sodium, fluid, and magnesium are also under control. Blood pressure also needs to be controlled in chronic kidney disease. Target blood pressure is 125/75. Drugs of choice include ACE and ARB. Calcium channels can also be used. Anemia treated with hormone injection per week and with iron, folic acid supplements. Blood transfusions are avoided unless necessary. Renal metabolic bone disease is treated with phosphate binders like calcium carbonate, aluminum hydroxide. Vitamin D is also supplemented. Ultimately, patient with chronic kidney disease will have to undergo dialysis or kidney transplantation. There are two types of dialysis, hemodialysis and peritoneal dialysis. The picture here a hemodialysis. In hemodialysis, a dialysis machine and a special filter called an artificial kidney, or a dialyzer, are used to clean your blood. To get your blood into the dialyzer, the doctor needs to make an access, or entrance, into your blood vessels. This is done with minor surgery. Peritoneal dialysis is a type of dialysis which uses the peritoneum in a person's abdomen as the membrane through which fluid and dissolved substances are exchanged with the blood.